So today we'll be covering Chapter 9 over, we'll talk about anesthesia and the different drugs used for anesthetics and putting a patient to sleep. In history, we have used pain medications and alcohol for sedating patients to help with sedation and also to help with pain. We don't use this, well, we still use pain medication, but we don't use alcohol anymore. That's what the surgeon drinks during, before surgery. But anyway, we'll be talking about a couple different types of anesthesia today. We'll be talking about general, then we're talking about local, and with local, we can actually even break that down to regional and then local. So if you want to think about it as general, regional, and then local. And again, the big difference between this is with general, the patient is going to be asleep. You're going to actually sedate the patient. With your regional and with your local, the patient's still going to be awake, but you'll just make that particular part of the area numb and you'll make the patient happy. Lots of different ways with general to get that into the system, inhaled, rectal, IV, neuromuscular block, which as well, you're just ejected next to the nerve. So what you're doing is you're causing or you're inducing CNS depression. That's important to realize when we talk about the complications with anesthesia and about some of the potential side effects, because what we are actually inducing here. Some of the effects, we are decreasing cerebral metabolism, but we are increasing cerebral blood flow and intracranial pressure. So this is important if the patient has had some type of head trauma, maybe a car accident or anything to deal with head trauma. You have to be careful with that. Also, it's going to make the patient more sensitive to arrhythmias. So if the patient has a cardiac condition, this can be a complication as well. And also with respiratory, when we are causing this CNS depression, that's also going to affect respiratory as well. And we actually will, during surgery, during general, the patient will stop breathing and we'll take over breathing for the patient, using a ventilator. With our renal, we have decreased renal blood flow, so if the patient has kidney problems, this could be affected as well. And high-risk patients, again, which would make sense with respiratory and cardiac problems. I'm not going to spend a lot of time on this. Again, that does not mean it's not important. You won't see it again because you will see it again, but I'm just not going to spend a lot of time on this part because it's pretty well just there. But with the gas, we specifically talked about nitrous oxide. We talked about that quite a bit on Monday, so definitely look over that. Diethyl ether, this one really is not used for surgery anymore. It's used quite a bit in chemical labs as a solvent. Same thing with chloroform. They use this quite a bit in labs as well. Again, with the general, the patient's going to be asleep. And with our local, the patient's not going to be asleep. So there's sort of one of the huge differences between the two. And also how much we're either having pain-free or if the patient's asleep, then they'll be pain-free there. And a good example with this, with the local, is probably dentistry, used quite a bit. With regional, like epidurals is a big one with example of a regional. And again, regional, that's just going to be a larger area. You may administer pre-anesthetic medication, and not just sort of pre, but during surgery itself. So, and if we take a look in our book, oh, well, I'll have it on the next slide. This is in your book as well. You'll typically be given some type of anti-anxiety medication, and the big one here, midazolam, is probably the most popular, which is Versed, and that is a benzodiazepine, but also, you know, diazepam or any of the benzodiazepines can be used here. Same thing with the opioid analgesics, any of the pain medication. Probably fentanyl is probably the most common to use. And you may see atropine and think, you know, why atropine? But if you remember what is happening during surgery, the anesthesiologist will be monitoring the patient. So if there is complications or potential complication in surgery, they may have to administer atropine. Characteristics of anesthesia. All this makes sense. I'm not going to go over that again. Self-explanatory. Different stages. I'll briefly go over the stages. Briefly. Again, that does not mean it's not important. Stage 1, this stuff happens. So we start to have some euphoria. We start to get some pain-free stuff happening. May start seeing things or hearing things. And then we start to go into stage 2. All that increases. In addition to that, you're probably going to have some, the breathing is going to slow down, and with stage 3 and 4, that's when it's going to stop, and you'll intubate the patient then. You'll start to have loss of consciousness in stage 2. And also with stage 2, make a note here about the tachycardia, which is what increased heart rate, hypertension, because the body is trying to maintain homeostasis, and you're trying to force the body to do something it doesn't want to do. So the body's like, whoa, wait a minute here. What's going on? Here, stage 3, this is where the respiratory is where the patient's going to stop breathing. So at this point in time, you'll start to intubate the patient, take over breathing for the patient. Why does it happen so quick?
Doctor's asleep. I was talking and I was just gone.
Yeah, it's very quick, the onset of action. Very quick. They gave you a general, I'm assuming? Mm-hmm. Okay, so more than likely they gave you propofol. And the onset of action of propofol is extremely quick. As soon as you start administering, within seconds, the patient's out. And then when you stop the drip, the patient's going to wake up within seconds. So it's just the onset of action. As far as gas, we already talked about the nitrous oxide, laughing gas. We've already talked about that. I don't go over that again. Here, we'll mention this about the with the general anesthetics, dissolves much more easily in lipids than in water. So if you want to make a note about it being fat soluble, and they block or they close the sodium channels, preventing the neurons from conducting. Very important. Both bullet points, but here, to summarize this, just fat soluble. To summarize this one, it's just blocking the sodium channels. Yeah. Adverse effects. What is nitrous oxide? I'm not going to go. I already went over that, so I'm going to go over that again. Precaution of pregnancy makes sense. With our injectable medication, so at this point in time we have got some IV established with the patient. There'll be the muscle tone will relax. Now we'll talk very quickly about local. This is going to be either to a region of the body or to just one area, like again with sutures, if patients cut their finger or something, you're just numbing that one area. But the big thing here is the patient is still awake. There's no loss of consciousness. The patient is still awake. And here's the progression of what happens with local. I've already went over that on Monday, so I'm not going over that again, but it's just sort of self-explanatory. We start with pain and we work down. With lidocaine blocks, as I mentioned before, with lidocaine, well, we typically think of lidocaine, we think about it being used as an anesthetic to numb an area, but also lidocaine can be used to treat something called PVCs. And this is important. You will see this again as well. And PVCs stand for premature. It's a heart. It's an arrhythmia with the heart. So in the heart we have ventricles, right? So premature ventricle contractions is what that stands for. And the first sign of lidocaine toxicity is what? Numb lips. Very good. So you will also see lidocaine in combinations with epinephrine, and the reason why is because it will cause vasoconstriction. So when you administer this as a local, it will not only numb the area, but the epinephrine will cause vasoconstriction, so the lidocaine will stay in the area longer, and that you'll also decrease bleeding. And again, with local anesthetics, what we're doing is we're just blocking that nerve impulse between the peripheral and the central nervous system. So we're blocking the nerve impulse between the peripheral and central nervous system with local. Okay. And again, what we're trying to do here is prevent pain. So used for minor surgical procedures and really very, very common in dentistry, but also with, again, in the ER, for example, it's used quite a bit there for procedures. The two main types of local is going to be esters and amides. And this is, again, just has to deal with the chemical structure. And there's a list in your book, and I think there's a list. There's not a list here, is there? Okay, there's a list in your book. You might have to glance over that list just so you have an idea of what we're talking about. You don't have to do it now, but I would glance over the list. And with the esters, patients who have an allergic reaction to esters, which is very common, it is because this para-aminobenzoic acid, that is the reason that they are allergic to it. So the more common and safer type is the amide. So this is like an example. This would be lidocaine. And again, all we're doing is blocking sodium. That's all we've done today, and we'll continue doing that. So with local, we're just stopping that nerve conduction by blocking the sodium channels. So we're blocking that nerve impulse from the peripheral to the central nervous system. All right. All right. As far as uses, lots of uses of why you would give a local and also a regional. So I'm not going over all these, but makes sense. There could be some systematic toxicity, especially if it gets in the bloodstream. You really can have some potential problems, depending upon how much and also how what conditions the patient has. If the patient's healthy and some gets in the bloodstream, you're going to be fine. If the patient is not healthy and it gets in the bloodstream, the potential for adverse reactions is going to go up. Some interactions with lidocaine. For the local anesthetics, lots of different ways. Topical, they even have cream, spray, injectable. So lots of different ways. So here's an example of topical. Here, what the dentist is going to inject it, so it will block the filling in all these nerves. Same thing here, so with like an epidural or with the spinal tap as well. With our topical, so again we replace this on like the top of the skin for something. Same thing with the potential side effects, how it works. Example again would be lidocaine, would be an example of a topical anesthetic, but like lidocaine ointment or something. Or there's also over the counter, I think it's called Lidocaine. I believe it's 1% lidocaine as well. A nerve block, so with a nerve block you're just blocking that nerve and the branches of that nerve that it goes to, like on the little picture a moment ago. And also could be used for small areas or large areas if you're doing a regional, but same principle. With our spinal, for example, this would be like an epidural. Now, most common used during labor and delivery. Now I'll talk about conscious sedation. This is something that you probably just haven't thought of. I'll spend a little more time on this again because this is important. Not that the other stuff is not important, it's all important. But you may end up doing a procedure on the patient and you want to make the patient comfortable, but you still want the patient to be awake to where they can perhaps move or take maybe a deep breath or do something. If you're doing some examples here, endoscopy or colonoscopy. Also with the heavy electrocardiogram, you would also could add on that electrocardiogram, perhaps leading to an angioplasty as well. And again, the patient's going to be awake during the procedure, but they're going to be happy. So you'll make the patient pain-free, and you will also give the patient some type of a benzodiazepine like the Versed. Remember, Versed can cause amnesia, so the patient may ask you the same question 4 or 5 times within a short time period. And this is, someone may have had a procedure where they had the conscious sedation. The patient is going to be pretty happy. They could do the surgery on themselves because they're going to be so sedated to a certain extent. So, but with that said, the patient's still going to be monitored in case something starts to happen to the patient. And some of the reasons why I just went over a moment ago. For relaxation, the patient's going to be comfortable. The patient may have to help do something. Very rapid onset, and as far as it's going to wear off very quickly as well. But there are some potential adverse reactions, but the patient will still be monitored during the procedure. That is it. We're done.